platform, and Nitin Kapoor will be doing the Q&A.
Okay, fine.
Okay. So Nitin Kapoor and Anjali will do the Q&A then in the second after you both finish.
Yeah, sure.
All right. So Anjali, I'll hand it over to you. I'm in the background. I'm muted, but
Sure.
I'll allow you to introduce him.
Sure.
Yeah.
First of all, wish you, Kalyan sir, a very good evening, and everyone who has joined here. We are so thankful to have you here on such a wonderful and important topic from our day-to-day clinical practice, especially for diabetologists and physicians who are working in diabetes. Preventing worsening of CKD for diabetologists, as we understand India as a population, we have huge number of patients with diabetes at a very younger age, and I would say a longer lifespan. And it is invariable to see many of our patients with diabetes land up in CKD. And the initial stages of CKD up to the time when they require renal transplant is something that diabetologists must be very well aware of how to handle. And I think that is where a very important talk by Dr. Kalyan sir is going to be very interesting. At the end, we have Q&A. So all our doubts are going to get cleared. So to start with this very important and interesting talk, I invite and have the privilege to have Dr. Kalyan Kumar Upadhyay, who is a very senior endocrinologist. Both our speakers are from UK. He has been an investigator in several clinical trials, had been a consultant in diabetes at University Hospital, Birmingham, UK. Won prizes in UK, Stephen Whittaker Prize, Owen Wade Prize, Endocrine Society Prize, Nasi Prize. Publications, he has more than 25 international publications, almost equal amount of national publications, a lot of publications, abstract publications in international journals, a lot of book chapters. Currently, he is consultant in endocrinology at CK Birla Hospital, Kolkata. And I personally have been listening to his talks at many platforms all over the country, and would like to look forward to listening to you, sir. So over to you, sir, for your presentation. Looking forward.
Okay, thank you very much, Dr. Bhatt, for your kind words. So I'm going to share the screen. I hope my screen is visible and I am audible.
Yes, sir. Your screen is very well visible. The
Okay,
point
fine.
is visible. If you would like to change the slides and see if it's moving properly.
Yeah, is that
Yes.
okay?
Yes, sir, it is moving properly. Perfect. Rahul is there at the background for any audio-visual problems, sir. But I don't think there should be anything. This platform has been working very well. We have taken it for IDEC and it works wondrously.
Excellent. Good.
Thank you, sir.
So, yeah, thank you. So I think when Sanjay first told me, Shomit had a chat with him, and Shomit said that, look, the IDEC cafe, the audience is quite high profile. And so your talk should be like that. I said, fine. So I have made it like a case-based discussion rather than throwing everything theoretical. Because in CKD management, it is not plain and simple, straightforward that we get in trials that is not replicated in our day-to-day practice. We get all sorts of combinations of GFR and urine albumin creatinine ratio. And that is what I'm going to show in the cases, what was there before and what advances have happened now. And at the very end, about 5 minutes of the presentation will be in the future. There are quite a few exciting molecules in the future, which will take up, I think, another 3 or 4 years for them to materialize. So now the KDOQI guideline, now this everybody has read, learned, seen 1,000 times. The important thing here is, so as I said, I know that this is a learned audience, so I'm not going to bore you with the usual barn door slides that you have seen 1,000 times. Now, the KDOQI guideline, they have said about diabetes with CKD, apart from lifestyle and self-management, first-line drug therapy would be met for. So first, lifestyle, let me start by saying that lifestyle and self-management is a given. That's the platform on which everything occurs. So apart from lifestyle, think about lipid profile, think about blood pressure, smoking. So that's there. Now, second, first line drug therapy. So they put metformin, SGLT2, RAS blockage, and statin. Now, statin is there and that is separate. The question comes between these two, SGLT2 and RAS blockade. Which one to give first? What is the hierarchy? Which cases you will give RAS first? Which cases you will give SGLT2 first? Or should you start with both together, one after the other? That actually, if you look at it carefully, it's not very clear. Now, I would quite like at the end of this discussion to have a friendly banter, a bit of fight amongst ourselves regarding these and subsequent points that I'm going to make. Now, I'm going to show you some 4 cases, and I'm going to then show you the data as to what to do in such cases. Now, this is all the cases are 62-year-old patient. The type 2 diabetes duration is also the same, except for the last, which is 13 years. Now, the difference starts. So this patient does not have hypertension and technically does not have the diagnosis of CKD, because CKD means eGFR of less than 60 and or ACR more than 30. So normoalbuminuric, normotensive, not CKD. What can we do for these patients to prevent progression to CKD? Second group, there is albuminuria now, but not hypertensive. Third, hypertensive, but not albuminuric. Fourth, hypertensive and albuminuric. And the fifth, hypertensive, but the eGFR is less than 30 and there is no albuminuria. So that's the main difference. The eGFR of the others are same. Now we'll go one case at a time so that there is less of confusion. So this patient, non-hypertensive, normoalbuminuric, non-CKD patient. What can we do to prevent this from progressing into CKD? Now, if I put this, so I've added few dots from here. So you can see here, now this needs to be looked at it a little bit carefully. Now, on here, so I'm trying to fiddle with it. So here is the ACR. So you can see here the ACR is going up. And here is the eGFR going up here. So a patient, if you can see my pointer, a patient who is here has got does not have CKD eGFR wise and does not have ACR CKD wise. So that's pure patient. So our patient is somewhere here. Albumin creatinine ratio less than 30, and eGFR is 66, so somewhere here. So what data did we have so far to say that if we do this, then that will help prevention of progression to CKD? Yes, that is given, that blood pressure monitoring, lifestyle, everything else, that is there. But on top of that, now, beforehand, we only had the data with the ACE and ARB. So if you look here carefully, I put the data with the ARB here and here. So this is renal with losartan, IDNT with irbesartan. But look at the mean ACR. Their ACR is more than 1,000. And eGFR is also less than 40. But that is not our case. Our case is somewhere here. So we have got data with the ARB here, innovation with telmisartan, ARMA with irbesartan, where their eGFR is more than 60, more than 75 actually. But they are not albuminuric. So all they have put here, because this is 200, they were microalbuminuric patients. So at least more than 30. So not albuminuric. So all in all, there is absolutely no data, no trial done in patients who are normoalbuminuric and normotensive to see if we can prevent their progression to CKD. So we therefore rely on data which we can get. So this is the KDOQI guideline, which says that available data suggests that ACE and ARB are not beneficial for patients with neither albuminuria nor elevated blood pressure. So this is the first case which I showed you. So now this is the EMPA-RAGE, CANVAS, and DECLARE-TIMI. So the CANVAS, the median ACR was 12, and eGFR was more than 70. MPAR age, 60% of patients had ACR less than 30, EGFR more than 70. Declared TIMI, more than 70 had ACR less than 30. And so this quite simulates our patient, which I just showed you. But their primary outcome was not renal. So renal is the extrapolated outcome that we all have seen subsequently, because this is not a renal trial. So whatever data we could get out is from this, and that is all we can rely on. So I think if you ask me, a patient normoalbuminuric, normotensive, what can we offer in 2024 to prevent progression to CKD? The answer is data extrapolated from the SGLT2 trial is SGLT2 inhibitors. That's the best we have got. There's no dedicated trial. I'm not aware that there is any dedicated trial occurring in this group of patients. Now, the second one, no hypertension, but there is albuminuria now. Okay? So non-hypertensive albuminuria. Now, again, if you go back to KDOQI, they have said the benefits of rash blockade have been less studied in diabetes and CKD without hypertension. So IDNT trial here at the top, you can see the IDNT at the top here. They, a small percentage in the renal trial, 3.5%, and in the innovation, about 30% of patients were normotensive. That's it. So based on that, we can say that yes, RAS blockade may be beneficial in patients without hypertension. So my question, if I ask, so suppose somebody is normotensive, type 2 diabetes, and has albuminuria, what should I offer first? Should I offer the SGLT2 first, or should I offer the RAS benefit blockade first? You know, you won't get an answer in any guideline. But I think, looking from what I've shown you so far, I think probably I will offer the SGLT2 inhibitors first, because they have got much more data in the normal EGFR group as compared to the ASM, or as compared to the RAS blockers. So I think next case is type 2 diabetes, hypertensive. Now this time hypertension has creeped in for the first time, but there is no albuminuria. How to prevent this? Of course, good blood pressure control by any means will prevent their progression to CKD. But apart from that, again, if you look at the other trials, KDOQI guideline again, 2022, patients with type 2 diabetes and hypertension are at lower risk of CKD progression when ACR is normal. Existing evidence does not demonstrate clear clinical benefit of RAS inhibition for CKD progression in this population. Why? Because all the RAS inhibitors trials, almost all of them, had included patients with ACR more than 30. We really don't have that much of data. Even in hypertensive patients with type 2 diabetes, if there is no albuminuria, then the benefit of RAS blockage, we do not know. So the problem is, I've kept saying that we will have to think about SGLT2 inhibitors again as first choice here. Because if you remember, everywhere is there in the guideline that if you have type 2 diabetes who has got blood pressure, if there is no albuminuria, you can choose from either a RAS inhibitor or calcium channel blocker or beta blocker. So you can choose other agents other than RAS. If there's albuminuria, you choose RAS inhibitors. But if not, then you can choose others. But my question is, I'm leaving aside the blood pressure antihypertensive choice. What else we can do? I think SGLT2 inhibitors again will come in here. But the SGLT2 inhibitors are not antihypertensive agents, are they? They are not. Yes, they do cause reduction of blood pressure. But the other thing is, I'm keeping emphasis on the SGLT2 inhibitors here. But one thing we must not forget, that most of the trials, they had RAS inhibitor on board. About 70 to 80% of the patients were already on RAS inhibitor. So if one of you protest and say that, look, you are telling about SGLT2 inhibitors causing the benefit, but 80% of the patients were on RAS inhibitor when the SGLT2 inhibitors were introduced in these patients. What then? How do you say that the SGLT2 inhibitor on its own is causing the benefit, not because it is combined with RAS? So very difficult to answer that. The subgroup analysis have shown that whether you have got RAS or don't have RAS, the benefit is roughly the same, but that is comparing 80% with 20%. Now, the third patient, case 4, here you have got hypertension and albuminuria. This is easy. Now, here, I think we should give the RAS inhibitors first because there is data with the RAS inhibitors, hypertension and albuminuria. There's clear data here, and few more. So here, I won't hesitate in giving the RAS inhibitor first, and then perhaps SGLT2. And then I will be saying, yes, I'm happy because most of the trials do support that. And what about the last bit? Now here, the eGFR is now for the first time in the CKD range, and more so in less than 30 eGFR, but no albuminuria. Again, I've said just now that the data with RAS inhibitors in the absence of albuminuria is pretty poor. So what to do now? So this is the data with the SGLT2 inhibitors and SGLT2 inhibitors and the renal trials. Sorry, I'm just trying to fiddle with the bar here. So you can see here the credence, DAPA, CKD, and the EMPA kidney. So the good thing about the EMPA kidney here particularly is that about 20% of the patients had ACR less than 30. So therefore, an eGFR, I think less than 30 is 35%, and 20% is less than 30 ACR. Now, what proportion of the patients had both eGFR less than 30 and ACR less than 30? I can't tell you, I don't know. But because this was the first time that you have got patients, because you can see the others, it was 0 or less than 1. So normal albuminuric, but eGFR YCKD, this is the data that you have. So based on this, we can say, yes, SGLT2 inhibitor would be ahead as protection against CKD. So now the other question often asked is that up to how low eGFR can we give the SGLT2 inhibitor? Now the KDOQI guideline is pretty clear. Now you see here, and this has to be read word for word, word by word. So SGLT2 inhibitor initiate if eGFR is more than 20. Then this has to be remembered because many times I hear the word 30. No, it is more than 20. And continue until dialysis or transplant. So suppose you start somebody in eGFR was 31, and now it is 21. You continue. Now it is 19. You may continue. 18. You may continue. Dialysis has started. Now you stop. This is what the KDOQI guideline shows. Albeit you lose the glycemic lowering ability of the SGLT2 inhibitor when the eGFR drops, but the renal protection and the cardiovascular benefits are still there, so you can go up to dialysis time. Now, these are the various ones. I think the canagliflozin is up to eGFR of 30. Dapagliflozin, you can see here, I think it's written for some reason, it's not coming up nicely here. So dapagliflozin 25 and empagliflozin up to 20. But in general, I think 20 is fine. So now the other thing is, now this I'm coming across a few times and I'm having fights with my nephrology colleagues here. So what is the fight with the nephrology colleagues? Because the patients have got slightly low GFR, and I've started them on the GFR of say 30, 31, 29. I've started them as SGLT2. They cut it and send it back to me. And the patient said that nephrologist had said they've given a toxic drug. It will further drop the eGFR. So I had a run-in with the nephrologist. He says, no, I've seen a few patients who have dropped their eGFR by 10 to 20% after starting SGLT2. Show me data. that if the EGFR drops, then you maintain the benefit? This is a question of an ask. So now, this is the data from the DAPA-HF. So initial decline, dip in EGFR patients, and what is the outcome? Now, if you see here, for some reason this is missing. This is EGFR, no change. EGFR dip more than 10%, dapagliflozin about 38% of the patients. So close to 40% of patients will dip the EGFR by more than 10%. And only 3% will dip by more than 30%. So what? Is the dipping bad then? What is the outcome of the dippers? If the GFR drops, what is the outcome? So if you look at that, so those who dip more than 10%, this is dapagliflozin, they have got favoring GFR, everything, CV death, heart failure hospitalization, total heart failure, all-cause mortality, everything favoring the SGLT, the dapagliflozin group, who dropped their GFR by more than 10%. And on the other hand, the placebo group, who dropped their EGFR by more than 10%, do worse than that. So the SGLT2 inhibitor drop in EGFR, this group actually does better. So long-term EGFR decline, if you see here, initial EGFR dip, if there is no dip or increase, long-term EGFR dip is comparable to placebo. You can see the p-value is the same. But if the initial EGFR dip is more than 10%, oh, I've got a mistake here, sorry. My apologies, this is some typo I've done. So you can see the EGFR decline, this is wrong. So the EGFR decline in the placebo arm would be more than the dapagliflozin arm. So all in all, to take the two slides together, those patients on dapagliflozin who dropped their EGFR by more than 10%, they have got better CV outcome, and also their EGFR decline is much better or slower than if they didn't dip it. So remember, dip is good then, it's not bad. So another thing commonly asked is, when should we refer to the nephrologists? Now, this is the ADA consensus, joint consensus with the KDIGO. So here it says refer. So anybody who is having ACR more than 300, you should refer to the nephrologist. Anybody who is having EGFR less than 45, you should refer if they have albuminuria. So ACR more than 300, refer. EGFR less than 45, refer if they have albuminuria. Now again, I want to stir up a bit of controversy here. Why should I refer? What different thing will the nephrologist do if the patient is here? I can take the point that somebody has got EGFR, say ACR, say 3000. So yes, there is a nephrotic range proteinuria. I might be missing, glomerulopathies, focal sclerosing glomerulonephritis. I might be missing IgA nephropathy. I might be missing a lot of things. So sorry, am I audible?
Yes, sir, you're audible.
Just give me a second.
No worries.
Yeah, I think the noise was coming from somewhere. So I think if the EGFR ACR was, say, about 3000, then I might be missing focal glomerulonephritis, IgA nephropathy. Yes, I will refer. But if we say 320, what else will the nephrologist do? What I can't do? So I think this I dispute, and I think this we can discuss as to what best we can do. Now, the GLP-1 receptor agonists have come now in the kidney market. So in the renin-angiotensin pathway, it is postulated, not proven directly, that they may act directly on the renin-secreting cells of the juxtaglomerular apparatus. Apparently, their GLP-1 receptors are there. They may act directly there. They may downregulate at the tissue level. at the post-receptor level to cause benefit in the renal parenchyma. Now, in the proximal tubular lumen, they might block the NH3, and it acts somewhat like the SGLT2 receptor blockage as well. So some effect similar to that. But having said that, the GLP-1 receptor agonist, if you look, everywhere it's written that the meta-analyses have clearly shown that GLP-1 receptor agonists have got good renal outcome. I will dispute that. They have got good renal outcome. Here I've said composite renal outcome. If you include macroalbuminuria, if you include albuminuria regression, when you take out albuminuria as the marker and you just put doubling of the eGFR or reduction of the eGFR, then only rewind stands out. And this pulls all the others, and the meta-analysis gives you a positive. So all in all, the GLP-1s appear to be very good in reducing the albuminuria. But you see, DPP-4 inhibitors also reduce albuminuria. Pioglitazone also reduces albuminuria. A lot of drugs reduce albuminuria. But what is the use of reducing the albuminuria if you don't stop the progress of the decline of eGFR? So it's only apart from the rewind trial, none of them do so. So it's only the albuminuria effect which is there. But the flow trial will probably disprove it. So as you know, this is patients with, this was trialed in patients once weekly semaglutide in type 2 diabetes and CKD, adults with type 2 diabetes. Again, mind you, this is not eGFR or ACR less than 30. They're all ACR more than 100. You have to have ACR more than 100 and eGFR up to 75. So this first occurrence of kidney failure, persistent for 50% reduction in eGFR, or death from kidney or CV causes. Now, you can see the median UACR is about 568. So they were churning out a lot of protein. So apparently this was, the top line result is that it was positive. But again, we have to wait and see whether all this positivity was just because of CV cause or whether it did indeed stop the kidney failure from occurring. This we need to examine. But this is a pleasant surprise for all of us, not a surprise, but a pleasant news for all of us that there is another drug at least which can stop the CKD from progressing. So I've got another 5 minutes, which I will quickly go through. Now, the Fidelio and the Figaro is with the new MRA drug, which is the Finreron. So this MR overactivation causes CKD progression via various routes. For lack of time, I won't go into detail. And through those routes, inflammatory cells also causes cardiac damage. So the Fidelio DKT trial, which was primarily a kidney failure trial and secondarily a cardiac endpoint trial, whereas the Figaro DKT was exactly the opposite. But if you combine both of them together, so the Figaro was here, this is the heart trial, and Fidelio was here. So that means that Fidelio had sicker kidney-wise patients than the Figaro DKD. And here you can see here that, again, urine ACR less than 30, only 1.8% or 0.4%. Majority had ECR more than 30. And eGFR less than 25, only a few patients. So majority were in this range, 25 to 45. So this was another shot in the arm for us, that another drug has shown that it can reduce the decrease in eGFR 40% and 57%, in addition to showing good benefit in 3-point MACE as well. But if you put all of them together, so the ACE inhibitor trials, doubling of serum creatinine, ARB, that just about touches the midline. But the SGLT2 inhibitors, clear winner here. The MRA from the two trials, Finreron, it is somewhere here. You can see SGLT2 is a runaway winner here. CV death, no benefit with the RAS inhibitors, benefit with the SGLT2 inhibitors, no benefit with the non-steroidal medication, but in the right direction. And all-cause death, only SGLT2 inhibitor wins. So I think overall, if you ask me, and if you put my gun to my head, which one is the best? That is SGLT2. But again, you might argue that yes, you are saying SGLT2 is even better than the RAS inhibitors, but 80% of the patients in SGLT2 were on RAS inhibitors anyway. So the combination of Findenon and SGLT2 inhibitors therefore comes into focus. This trial will tell us whether there was, unfortunately, it will just tell us whether the urine ACR benefit was there. I was hoping that it would show whether the eGFR decline was prevented. But if you want to show, you need 41,000 patients for quite a period of time. So therefore, they can't do it. So we have to satisfy ourselves with just ACR levels here. So I think overall, if you include all of this, that is BP control, RAS, SGLT2 and mRNA, your eGFR decline, you can substantially reduce by a good few years. Okay, so I've got, unfortunately, I've almost run out of time. I think I've got another 3-4 minutes. So I'll just run through the future, I think. So those who don't want to know about the future, you can shut your eyes now. So this is a group, I think, the JAK-STAT inhibitors. So first of all, when it first came, I tried to get around what is exactly JAK-STAT. You know, just JAK, JAK was initially, it was just another kinase. Then they came up with the name of Janus kinase based on 2 Greek words. So it is like this, the cytokine receptors that are there. And then when the cytokine is attached to the cytokine receptor that pulls in the JAK together, the JAK then donates, phosphorylates each other. By doing so, it phosphorylates the entire receptor as well. And when it phosphorylates the receptor, STAT comes in to grab hold of this phosphorus, which is dangling out of the cytokine receptor. When it does here, another STAT comes here. Then these 2 STAT go down, and then they may dimerize into 2 STATs. These might be the same family or different family. When they dimerize, they go into the cells, into the nucleus. Then they cause gene expression, and that leads to a lot of good and bad effects both. So you've got multiple JAKs, multiple STATs, so multiple effects. So some of them will cause inflammatory factors and fibrotic factors. So what you can do is you can So you can see here, role of JAK and STAT. So what you can do is you can have JAK inhibitors here. You can have receptor antibodies here. How you can intervene? You can have inhibitor of the STAT getting detached here. So a lot of ways you can do it. And the many of the JAK-STAT inhibitors are already in practice in rheumatoid arthritis, ulcerative colitis, a lot of other diseases. I'll rush through it. So there are some which are being tried in CKD, which is baricitinib, ruxolitinib. They are being tried in type 2 diabetes. The last 2 slides, Nitin, so I'm going to finish now. So this, I think, I've just highlighted the ones which I thought was very interesting. So bardoloxolone, that's an NFT inhibitor. It had shown a lot of promise, actually. It was thought to be a wonder drug, but then some of the side effects of edema and heart failure crept in. Comparison between efficacy of SGLT2 versus ACE inhibitor in DKD. This should make interesting reading, EMPA versus enalapril, albeit not that many patients. Then you have got prevention of CVD and DKD in type 2 diabetes. Here you have patients, 9,000 participants divided into SGLT2 versus GLP-1 versus SGLT2 GLP-1. This will make a very interesting reading, which will be precedent D trial. And you have got the endothelin A receptors antagonist atrasentan as well. So I think I will end here because I have now exceeded time. So I think what I've highlighted is sitting here 15 years ago, or 10 years ago, we would have absolutely nothing apart from RAS inhibitors. Now you have got multiple drugs more, and now the competition has who is going to come ahead of the RAS inhibitors in this race. But I feel RAS inhibitors have their place and they will stay. But the newer drugs sounds and looks very interesting. I'm a bit worried about the JAK-STAT inhibitors. I'm a bit worried about the endothelin receptors, NF2 2 receptor antagonists. I'm a bit worried about them because they're ubiquitous. They have got a lot of other functions as well. So if you block them or stimulate them, some of the other side effects will creep in after a few years. So based on that, I feel the safest is the SGLT2, are the SGLT2 and the GLP-1 receptor agonists. And Finderone so far has not caused any trouble apart from the hyperkalemia. So with that, I end. Thank you and sorry for exceeding 2 minutes of the time.
Thank you so much, sir, for that very, very explicit lecture, dissecting all the trials, making it really simple for anybody listening, and most importantly, giving your very unbiased opinion, irrespective of what the guidelines say, but giving a scientific rationale as to what should be the real practice, and also mentioning about the future of the CKD management in diabetes. I think you've made really life simple for a lot of our listeners. There are a lot of questions that are pouring in. We'll come back to them in a while after Dr. Binayak's talk. And I think let's directly move on to our next session, which is changing gears from kidney to the heart. And we are now wanting to listen what we really need to know about preventing or worsening cardiovascular disease, what the diabetologist needs to know, what is the recent literature on it, recent advances, but also a glimpse into the future. And we have another great speaker today with us. We have Dr. Binayak Sinha, who's a trained endocrinologist, done his CCST from the UK, currently a consultant diabetologist and endocrinologist at Ambry and Fortis Hospitals in Kolkata, and previously also worked in Birmingham. So has got Young Investigator Award by the International Congress of Endocrinology in 2002, several orations to his credit, co-author of several handbooks, and has taught several courses across the country. So also serves as the editorial board member of multiple peer-reviewed journals and also is the associated editor of Cardiovascular Diabetology. Indeed, the right person to address the topic, preventing and worsening CVD, what we know, what are the recent advances and what the future is. The stage is yours, sir. So if you could unmute, yeah.
Nitin, thank you so much for kindly introducing me. We'll move directly on to my presentation, which basically is, complementary to what Kalyan just spoke about, and I think this topic, Sanjay told me speak on CVD. This was a broad brief that was given to me. And I spoke to Kalyan and he said he was talking about preventing worsening of CKD for the diabetologist, recent advances in the future. Now, fortunately or unfortunately, the kind of debate or discussion that exists on kidney disease has almost been put to rest by the amount of data that has been generated in cardiovascular disease as far as diabetes is concerned. Guidelines are pretty much straightforward to the point, and the data has been dissected and debated and taken to the cleaners too many times for me to dissect them again today. So I'll go through what is the latest situation as far as diabetes and heart disease is concerned, showing you what the guidelines are telling us to do, because that in itself gives us a very strong idea of what we should be doing to prevent heart disease or the progression of heart disease in our patients with diabetes. Not only that, it will also give us a rough idea of how the things will progress in the future. And I promise that I will not spend too much of time on the future, because actually the amount of literature that I am expecting to come out and I am looking forward to publication is actually not that much. So diabetes, as you know, leads to oxidative stress with inflammation, insulin resistance, and obesity. And this in turn leads to atherosclerotic MACE events, which cause CV deaths. And on the other side, it also leads to heart failure events, which also in turn leads to CV death. We know diabetes is associated with high cardiovascular risk, with an increased risk of coronary artery disease, stroke, and heart failure. And it is associated integrally with hypertension and dyslipidemia. So the general paradigm seems to be that you manage A, B, and C. A1C, blood pressure, and cholesterol to target improved cardiovascular outcomes in patients with diabetes. Now, the management of cardiovascular disease in diabetes, it's become pretty much clear. So if you have cardiovascular disease and type 2 diabetes, there is class 1 evidence, that is top quality evidence, that you should be trying to treat the cardiovascular risk independent of glucose control in patients with type 2 diabetes and ASCVD. And the treatment options are GLP-1RA, which has got class 1A evidence, as well as SGLT2 inhibitors. Now, if the patient has type 2 diabetes and then goes on to develop cardiovascular disease, then again, if it's heart failure, we go for SGLT2 inhibitors. If the patient has chronic kidney disease, we think of SGLT2 inhibitors and finerenone. Now, what is interesting about all this data that I'm showing you, as you can see, this is taken from the ESC latest guidelines published a few weeks ago, is that this is all class 1A evidence, which means there is little or no doubt that this is what we should be doing. So there's little to debate as far as these drugs are concerned. And this is on the basis of the CVOT trials of available anti-hyperglycemic agents, which have been completed after the issuance of the FDA 2008 guidelines. So this is a rough estimate of all the trials that have been done. Green is GLP-1, orange is SGLT2 inhibitors. And we all know, the GLP-1RA has come up with brilliant trials in the form of LEADER, SUSTAIN 6, Harmony Outcomes, REWIND, Amplitude O, and Freedom CVO, which is not really in public domain to that extent. We know about the success of EMPEREDGE outcome. We know of CANVAS. We know of DECLARE. VERTIS, which in effect was a less overwhelming trial. The trials with short-acting GLP-1 receptor analogs like ELIXIR and EXCEL were not successful. The PIONEER 6 with oral semaglutide, though it showed a marked positivity in reduction of 3P MACE, was not powered to actually give us an idea about whether we should consider it superior to placebo in reducing cardiovascular outcomes. The DPP-4 inhibitors are kind of innocuous drugs which do not cause any benefit or any harm in heart disease. Now, what is interesting to see is the meta-analysis of the SGLT2 inhibitors. If you look at it, the amount of data that is there as far as reduction of heart failure is concerned, there is little or no doubt that there is a marked reduction with a big effect size in usage of SGLT2 inhibitors in patients in reduction of heart failure. In ASCVD, there seems to be some benefit in patients who have established heart disease, but not so much in patients who do not have established cardiovascular disease. And this has been something that has been borne out by multiple meta-analysis and multiple data that has been published since then. The data with GLP-1 receptor analog GLP-1 receptor analogs with sensitivity analysis removing ELIXIR, because ELIXIR is a slightly different trial from all these trials, shows a marked improvement with a very impressive effect size in all aspects of MACE. There is a significant reduction of 3-point MACE, cardiovascular death, fatal or non-fatal myocardial infarction, and a very impressive reduction in stroke with the usage of GLP-1 receptor agonists. So naturally, the treatment paradigm has been designed with this in mind, though we still have guidance as to provide for a relaxed glycemic target in patients with short life expectancy with tight glycemic percent control of less than 7% in patients who have longer life expectancy. There is another thing that is being taken into consideration, that is the risk categories in patients with type 2 diabetes. The patients who have established CVD or have a high risk of diabetes with the SCORE 2 diabetes criteria. Unfortunately, SCORE 2 diabetes is not for Indo-Asians, and for Indo-Asians, I think the best option is still to go for the QRIS 3. We can classify patients according to very high CV risk, or according to high CV risk, or according to more moderate or low CV risk, and roughly use the same kind of criteria, greater than 20, 10 to 20, 5 to 10, and less than 5, even if we are using the QRIS 3 criteria, we can kind of classify our patients into the risk categories. So while treating our patients, we take two things into consideration: A, their life expectancy, and kind of develop an idea of how aggressively we treat their diabetes, and B is we frame them into cardiovascular risk categories. Now, according to cardiovascular risk categories, if the patient is at low risk, metformin is good enough with a class 2A evidence. If the patient is at moderate to high risk, the metformin can be given along with SGLT2 and GLP-1 receptor agonists. But in patients who have very high risks, it is only GLP-1 receptor agonists and SGLT2 inhibitors. And as you can see, in this group of patients who are at high risk or very high risk, we do not really start with metformin. We go directly for GLP-1 receptor agonists and SGLT2 inhibitors. We can concomitantly use the other drug for additional glucose control because, of course, we need to control for microvascular complications. But for CV independent, risk independent of glucose control, we have to go for GLP-1 receptor agonists and SGLT2 inhibitors in patients who are at high risk and at very high risk. We can also try other drugs like metformin and pioglitazone. We will come to pioglitazone again in a minute because on the one hand, there is some degree of evidence which supports the usage of pioglitazone in treating patients with diabetes. And on the other hand, as I will show you a little later, pioglitazone is actually thrown away with the bath water in the next few slides that I will show you. Drugs with proven CV safety are the gliptins, ertugliflozin, glimepiride and gliclazide, insulin glargine or degludec, and other GLP-1 receptor agonists. Other sulfonylureas and short-acting insulins do not have any cardiovascular data. Now we come to the other side of heart failure, of heart disease and diabetes. And actually, as we all know, this is probably the more important part of heart disease because, most of our patients, even before they develop coronary artery disease or a blockage in their arteries, will go on to develop some degree of heart failure if they have diabetes. There is pretty convincing data that even if the patient is asymptomatic or the patient does not have any kind of positive test as far as testing is concerned, echocardiographic findings will show that almost 60% of patients with diabetes after 5 years of diabetes will have some degree of diastolic or systolic dysfunction or both. So we should regularly evaluate patients of diabetes for heart failure. Symptoms, signs are the best way to go for it. If there is signs of symptoms of heart failure or an abnormal ECG, we should go for an NT-proBNP. And if that is high, we should go for an echocardiography with structural and all functional cardiac abnormality. Heart failure is confirmed. We classify the patient according to 3 classifications: reduced ejection fraction, moderately reduced ejection fraction, and preserved ejection fraction, 50, 41 to 49, and 40% reverse respectively. So this is how we go ahead and treat patients with heart failure. But the important thing in patients with diabetes is to suspect heart failure. A lot of our patients come and complain of there is some shortness of breath and exertion. They complain of easy fatigability. And these are things that the newer guidelines are telling us not to ignore. They are telling us to try and make a diagnosis early on as far as heart failure is concerned, because there is convincing treatment today that provides us with improvement in outcomes of heart failure. So you've got data coming out from high-risk diabetes in patients with CKD, HFpEF, chronic HFrEF, and worsening heart failure. And as you can see, the number needed to treat as far as worsening heart failure with gliflozins is 10. So if you treat 10%, one person's life is saved. Even in chronic heart failure with reduced ejection fraction, it is about 21 to 36. In HFpEF, it's less than 60. CKD, it's about 75. And in patients of high-risk diabetes, between 96 and 400. So as you can see, across the board, from Declare TIMI to EMPA Kidney, Virtus CV, EMPA-REG, DAPA CKD, credence, emperor preserved, deliver, DAPA heart failure, emperor is used. And of course, the data with sotagliflozin, the soloist WHS, we find that there's a massive absolute reduction of risk with SGLT2 inhibitors per 100 patient years. And this not only is a risk reduction, or as far as absolute risk of there's a definite reduction of hospitalization and or cardiovascular death when compared to placebo. Therefore, no doubt, with class 1 evidence, SGLT2 inhibitors should be initiated in patients to reduce heart failure-related outcomes, and also in patients with established heart failure, SGLT2 inhibitors, SGLT2 inhibitors, SGLT2 inhibitors. And this is independent of HbA1c and independent of concomitant glucose-lowering medications. For additional glucose-lowering we can use GLP-1RA, sita and linagliptin, metformin, insulin glargine, and insulin degludec. There is now a red box for pioglitazone and saxagliptin in the latest ESC. So as far as pioglitazone is concerned, I find it very difficult to place it, considering that on one side, it is probably beneficial in reducing atherosclerotic cardiovascular disease, but is definitely harmful as far as worsening heart failure is concerned. We come to the other two aspects, the B and the C's of reducing cardiovascular disease. And hypertension is probably more important than glycemic control, I feel, as far as reducing heart disease is concerned. So blood pressure confirmed using multiple readings, including measurement on separate days to diagnose hypertension of more than 130 by 80, unless...
Only I am having the problem.
Hello, is there a problem?
No, I think it's quite clear.
Okay, I think it's a problem from my end, I think. Sorry, carry on, please.
Okay. So the one thing I keep on telling my patients, I don't know if you experience this in your clinical setting. You will often have a patient who has, a headache, goes to see a doctor, the blood pressure is 150 by 90, and the blood pressure medications are started. Now, I find this a little bit of an irritant because, just measuring one blood pressure reading and then starting off with medications is probably not warranted. And indeed, what I suggest is, regular blood pressure measurements over a period of time and then deciding on blood pressure medications is probably the order of the day. So patients with a blood pressure of greater than 140 by 90, we repeat office blood pressure or ABPM, and we then confirm the diagnosis and then start. People who have a high normal blood pressure of 130 by 139, diastolic 85 by 89, we should consider masked hypertension and consider out of office blood pressure measurements, which is either regular blood pressure measurements at home or ABPM. The treatment initially is lifestyle with body weight reduction, calorie restriction, regular exercise, and the DASH style eating pattern, which is the dietary approaches to stop hypertension, which includes reducing sodium and increasing potassium intake with moderation of alcohol. Increased physical activity has been shown to be beneficial. There is quite a bit of data that has come out recently as far as blood pressure reduction is concerned, and I've highlighted a few. The first one is accord blood pressure, which was a large number of patients with type 2 diabetes. Systolic blood pressure aimed was less than 120, and in the placebo arm, in the control arm, it was 130, and there was no benefit in the primary endpoint. In fact, there was some reduction of stroke, but this intensive control was not sustained, and adverse events were more common in the intensive group. The advance was a similar kind of a thing. There was a reduction in outcomes, but in the risk of death was not really maintained over a period of time. The HOT study showed no benefit as far as reduction of diastolic blood pressure is concerned. And these days, most cardiologists feel that the data is not enough to actually target a reduction of diastolic blood pressure. The blood pressure, the diastolic blood pressure comes down with age. And indeed, all the data that we have, except for a small subpopulation of patients with diabetes, and intensive diastolic blood pressure control does not significantly reduce any outcomes. Now, a little bit of a problem was the SPRINT study, which showed strict glycemic control improves MI, ACS, stroke, heart failure, and death due to CVD. And this was a systolic blood pressure of less than 120 compared to a systolic blood pressure of 140 in the control arm. However, the people who went in for this strict blood pressure control also developed a lot of electrolyte abnormalities and acute kidney injuries. The STEP trial, however, with a large number of patients who were elderly, including a large number of diabetes patients, showed that a blood pressure, if you maintain it below 130 systolic when compared to 150, improves the cardiovascular risk outcomes. So I think now the opinion of the House has become more or less constant that you need a blood pressure of roughly around 130 with a diastolic which is under control. There is no fixed diastolic thing. Maybe less than 90 is a good idea, less than 80 if you're lucky. But, I don't think there should be a very strict target of diastolic blood pressure. And as far as systolic blood pressure is concerned, a less than 130 is good enough for most patients with diabetes. And this is how you treat these patients. Start with one agent. If the patient has albuminuria or coronary artery disease, the patient should be on an ACE inhibitor. If the patient has coronary artery disease or albuminuria, otherwise it's a Hobson's choice. You can use calcium channel blockers or diuretics. If the blood pressure is more than 160/100 consistently, if the patient has albuminuria or coronary artery disease, we start with ACE inhibitors or ARBs plus a CCB or diuretic. And if the patient does not, then you can start any of the 2 or 3 options out here. Now, if the treatment is well tolerated, that's great. If the patient is not, then we start adding the other drug which is left behind amongst these 3 groups of drugs, ACE inhibitors or ARB, CCB or diuretic. If there's side effects, we naturally need to change the drugs. What is interesting to know is that as the 3rd or 4th line drug, there is now very strong evidence to suggest that you should add in an MRA to control the blood pressure. So if 3 drugs don't work, instead of going for a beta blocker, probably a better idea is to go for an MRA in the form of eplerenone or spironolactone. We finally come to the cholesterol side of things, and lifestyle intervention and therapy with monitoring is recommended. 3 groups have been classified: high risk, very high risk, and moderate risk. In moderate risk, the target is less than 100 milligrams per deciliter. If high risk, it should be less than 70, and very high risk, it should be less than 55. I have earlier showed you what is high risk, what is very high risk, and what is moderate risk. And that same algorithm holds true even in cholesterol reduction. We should go for a lifestyle modification with weight reduction, go in for high fiber diet, and intensive lifestyle therapy and glycemic control in patients with elevated triglyceride. Now, in patients who are not taking lipid-lowering therapy, the lipid profile should be taken at diagnosis and then every 5 years thereafter. Once a statin is started, we should check again in about 3 months' time and then annually to make sure that the patient is responding well to treatment. The mainstay of cholesterol treatment is statin, statin, and statin. There is no other thing, and I think I will dispel some myths out here with some comments that I will make as I go through this presentation. The primary prevention in people with diabetes who have no established atherosclerotic disease, patients should be on a moderate intensity statin. There is no role for what we do with some of our patients providing 5 milligrams of atorvastatin. That is wrong. We should stop. In patients with diabetes who have aged between 20 to 39 years with additional atherosclerotic cardiovascular risk factors, we may or may not initiate statin. I find myself being more and more careful with these patients because as we see, the number of people that we see being admitted to coronary care unit in their youth developing heart attacks is just continuing to increase. However, we have to be careful about starting statins in patients who are women, because there is a problem. If they decide to get pregnant, we have to stop the statin at that point of time. And as you know, stopping statin can lead to rebound rise of LDL cholesterol. For people with diabetes at higher cardiovascular risk, those with more than one or more atherosclerotic cardiovascular disease risk factors, including family history and smoking, you should probably go for a high-intensity statin therapy to target an LDL goal of less than 70. In people who are not managing to get to this target, we need to add in a ezetimibe or a PCSK9 inhibitor. In elderly people, 75 years already on statin therapy, it is reasonable to continue. And in people who are not known to have diabetes below the age of 75 years, they should be started on moderate intensity statin. Now, moderate intensity statin is 10 to 20 milligrams of atorva and 5 to 10 milligrams of rosuva. These are the two things that we have available in our country. And in high intensity statin, it's rosuva 20 to 40 and atorva 40 to 80. High intensity statin will reduce LDL cholesterol by 50%, and moderate intensity will reduce by about 30%. Low dose statin is not recommended in people with diabetes. Now, we have to get away from this practice and avoid this. As far as people who are going in for secondary prevention, they need to be on high dose statins. No two ways about it. At least 40 milligrams of atorva or 20 milligrams of rosuva in people who have documented coronary artery disease or who have had a stroke or TIA. In this PCSK9 inhibitors, the evolocumab and alirocumab are added in patients who are at high risk of CVD or people who have a familial hypercholesterolemia who are on a maximum dose of statin and yet not coming down to target, because this reduces LDL cholesterol to the tune of about 40 to 60%. But there has been no cardiovascular outcome trials performed to assess whether these group of drugs are beneficial in patients without established cardiovascular treatment. So essentially what we've been treating is LDL, LDL, and LDL. Now there's this tendency to start drugs like saroglitazar and fenofibrate for the treatment of hypertriglyceridemia. We should start moving away from this practice because it is not evidence-based. For individuals with fasting triglyceride levels greater than 500, you can start medication with icosapentaoic acid and not with fenofibrate or with a saroglitazar. In adults with moderate hypertriglyceridemia between about, say, 175 to 500, we should be treating the lifestyle factors, secondary factors like diabetes, chronic liver disease, nephrotic syndrome, and hypothyroidism. Statin plus fibrate combination is not shown to improve atherosclerotic cardiovascular disease, is not recommended, and this is from the latest ADA guidelines. Statin plus niacin is also not recommended, and bempedoic acid can be used in patients intolerant of statins. This is the kind of evidence that we have at this point of time, and using these drugs in non-evidence-based setting is a call out to danger. Now, there is no risk of, there is a slightly increased risk of diabetes with statin use. But if you look at a meta-analysis of 13 randomized statin trials with about 1 lakh patients, the odds ratio for a new diagnosis of diabetes is that there's about 9% increase, which means if you treat 250 patients with a dyslipidemia, you will get, for 4 years, you will have 1 additional case of diabetes while preventing 6 vascular events among these group of patients. So as you can see, it's a bit of a no-brainer. Statin treatment should be continued without the consideration for diabetes. Antiplatelet agents in aspirin can be used as a secondary prevention. In patients who have aspirin allergy, clopidogrel can be used. We use dual antiplatelet in patients with an acute coronary syndrome or an angioplasty or a bypass for 1 year. Thereafter, we can just go to one of them. Primary prevention with antiplatelets is not routinely recommended. Now, as far as cardiovascular disease is concerned, in asymptomatic individuals, routine screening is not recommended. So it's pointless going ahead and doing a whole number of tests yearly to try and see if the patient has cardiovascular disease, if the patient has no symptoms. However, if the patient has some chest pain or dyspnea, or has some evidence of vascular disease like bruits, or has had a TIA, or has claudication or peripheral arterial disease, or some ECG abnormalities, you can go ahead and investigate. Probably the most useful tool at this point of time would be a CT coronary angiogram or a calcium score. So to take home, the lifestyle modification, diabetes education are definitely the first line as far as treatment of diabetes is concerned. Glycemic management has been streamlined. It is now SGLT2 inhibitors and GLP-1 RA, and then add in whichever medication you want to get to glycemic target. Blood pressure management according to albuminuria or CAD. Lipid management with statins, addressing the LDL cholesterol, trying to get them down to 100 or 70 or 60 as the case may be. And we should be using agents with cardiovascular and get kidney benefit. Now, though I said that we would be talking about the future, I only picked out three literature that I'm looking forward to, three pieces of literature. One is the SOUL trial, which is with semaglutide. This is interesting because this is going to be the first trial which shows the benefits or not the benefits of an oral GLP-1 receptor analogs. And I think it will be a game changer because for the first time, we will have an oral drug which will provide improvement of cardiovascular disease, reduction of MACE. There is going to be the STEP heart failure diabetes. As you know, the obesity trial was successful with reduction of heart failure as with semaglutide. The data with heart failure as far as GLP-1 receptor analogs has been pretty much missing. So I think this might be a step in the right direction. And of course, tirzepatide is going to come into the market as a very strong player as far as weight reduction in diabetes is concerned. But once the SURPASS CVOT is published, we will know whether it has also got atherosclerotic cardiovascular benefit in patients with atherosclerotic cardiovascular disease. Thank you very much for listening to me, and thank you, IDEC, for giving me a chance to speak here. Thank you.
Thank you so much, sir, for that fantastic lecture. You gave a lot of clinical pearls, right, from highlighting the very important point of highlighting or identifying heart failure in our patients with diabetes. Simple symptoms like lethargy, as you mentioned, and exertional dyspnea should not be missed. You've had spectacular clinical pointers with respect to dyslipidemia management, hypertension management. And I'm glad to share that at this point in time, we have 700 plus active viewers right now listening to you. And there are a lot of questions that are pouring in. And maybe it's time for having Dr. Kalyan back on stage, asking a few of the questions that we've got. And I'm afraid that there are so many questions, we wouldn't be able to take all of them, but at least we'll try and do justice to as many as possible. So if I may start asking questions first to Dr. Kalyan. Sir, thank you again for that brilliant talk of yours. The first question that has come is regarding management of diabetes-related CKD with SGLT2 inhibitors. And the question is specifically asking that these patients with CKD also sometimes have associated metabolic bone disease, the CKD MBD. And there was some initial data with respect to SGLT2 inhibitors increasing the risk of fragility fractures. So when we are using it in these patients with CKD, as you rightly said, up to the stage of dialysis, what would be your comment with respect to the risk of increasing fractures in them? So if you could unmute.
Yeah. So yeah, I think it's a pertinent one. I think initially, I think around about 2016, 2017, this was a concern. And in fact, animal studies did show that the bone turnover markers were increased with canagliflozin, not so with dapagliflozin and empagliflozin. But subsequently, there have been multiple meta-analyses. I think the largest one had tens of thousands of patients that clearly showed that there was no increase in the fracture risk. So I think overall, if you consider, Yes, there is some hint of increase in bone turnover markers. We know that there might be some rise of PTH, but overall, the meta-analysis have not really shown that there have been any increase in the risk of fractures. But the benefits far outweighs the risks, I think.
Thank you so much, sir, for clearing that myth. Many people have that myth, as you rightly said, several meta-analysis. At this point, metabolic bone disease is not so much of a concern with SGLT2 inhibitors. So the second question that has come is asking about patients, who've had a renal transplant for diabetes-related CKD, and whether in your practice or there isn't much data as of now in these patients after transplant, whether use of SGLT2 inhibitors has some role in preventing relapse or preventing progression of CKD in the post-transplant stage.
So I must admit I'm not aware, and I don't know. It's early days yet whether they prevent the rejection of transplant or CKD in the transplanted kidney. Yes, there is data of SGLT2 inhibitor use in the transplanted kidney now. I think real world data has come as well. Our worry is that they are on steroids, they are on immunosuppressants, whether they will cause higher risk of UTI, but that has not been borne out in the real world data that we have seen so far. But will it cause rejection of the reduce the rejection of transplant or reduce the progression of CKD? I don't know the answer.
Sure. Thank you, sir. So we just need to probably wait for more data on this. Moving on to the next question, and this is related to patients with obesity and diabetes-related CKD. And there is a lot of talk now of this entity called the obesity-related glomerulopathy. And so the question is whether GLP-1 RAs or SGLT2 inhibitors have shown benefit in nephropathy, and many of these patients are indeed obese. So is there a component of improvement of ORG which is contributing to overall improvement in nephropathy, or what is your comment on that, sir?
Yeah, so I think it's very difficult. There are so many overlapping things. Obesity also have got diabetes. They also have got higher metabolic diseases, hypertension, heart disease. So a lot of confounding elements are there. And the obesity-related nephropathy, I think one of the hallmarks from what I have read a little bit about it is that there is more of proteinuria and no edema. You can have huge amounts of proteinuria but no edema. That can be one of the characteristic features of this. There are no characteristic markers as such, biochemical markers available yet to say that this is obesity-related glomerulopathy. Yes, there can be sonographical evidence of ectopic fat deposition in the kidney, which might give a clue that it is obesity-related glomerulopathy. But at this point of time, I'm not convinced that making this as an entity will help us guide treatment, because we don't have clear-cut data whether the GLP-1 and the SGLT2 both have reduced obesity-related glomerulopathy or not. We just don't know. I think if I vaguely remember, I think if my memory serves me right, empagliflozin have got 2 trials lined up in patients for some empathy, I think. Yes, I remember this because I'm obese, so I sympathize with myself. So it's empathy trial. That's how I remember. Empathy trial, if I'm not mistaken, that's with empagliflozin in obese patients. But I'm not aware of any trial directed specifically at obesity-related glomerulopathy to see if causes reduction. I think it's only canagliflozin wherein they had teased out data on the obese patients, and they did show that SGLT2 did a better improvement in those patients who had obesity. But overall, I think it's still we need more data. We don't have enough data yet.
Thank you so much, sir, for sharing light on this less discussed topic. I think in interest of time, I'll just take 2 last questions for you, sir. Dr. Subrata Basu has asked whether SGLT2 inhibitors can be used in patients with single kidney.
That's a very interesting question. I think, I had one, I'm sure you have had as well. Binayak also had, and Sanjay also have. We have from time to time patients who have had nephrectomy. So the first impression is, so I then sit and ask myself, so why does this patient need SGLT2 inhibitor? What harm will the single kidney, what is the harm in giving to the single kidney? What are we afraid of? So RAS inhibitor, yes, you might make a point that if the patient has got renal artery stenosis, and it might, but for SGLT2 inhibitor, our main fear is, will it cause acute renal failure in a single kidney? The answer is no, because overall, in general, meta-analysis have shown that the acute renal shutdown is less with SGLT. Second is, will it cause urosepsis in the single kidney? Now, you see, if those patients who have got two kidneys, even they may have urosepsis. The SGLT2 related urosepsis is not localized only one kidney developing pyonephrosis, and the other one being absolutely fine. It is of both the kidneys. If there is no history of recurrent UTI, then the chance of urine infection becomes less. So if the patient has got multiple risk factors or atherosclerotic cardiovascular disease, and the SGLT2 inhibitor is clearly in the benefit, I would probably go ahead and give it to him, because the chances of him dying from those are much, much more than the chances of having renal failure or UTI, urosepsis-related death. As far as data is concerned, I did try and dig up, but I couldn't get many. There were some case reports, case series of 5 patients who had malignancy-related nephrectomy. They were given SGLT2 and nothing happened. They were fine. And I think the inclusion criteria for any of these CVOTs, there was no mention of exclusion of patients who had single kidney. I have not gone into detail to see how many had single kidneys, but there was exclusion criteria wasn't there that you have to have 2 kidneys. It was not excluded. So the answer is, if the patient has got multiple risk factors warrant use of SGLT2, I would probably go and give it. Sorry,
Kalyan, do you think it also, can I just ask, Kalyan, do you think it also helps in hyperfiltration damage to the glomerular single kidney?
Yes.
Because there could be hyperfiltration injuries, and there the SGLT2 may be beneficial to prevent gradual deterioration of the good kidney.
Yeah, I think it's a very good point you have made, Sanjay. So yes, so we know that when one kidney is gone, especially in a non-damaged kidney, somebody having a road traffic accident, or the other one having malignancy in the other kidney is finding. So there is hyperfiltration, yes. So I think that's another probably benefit of giving the SGLT2 inhibitor to a single kidney. Yes, I agree with you.
Thank you, sir. And I think that answer is also very important for all the voluntary kidney donors, who we keep under follow-up. And then, sometimes they also need medications in due course. So thank you so much, sir, for answering all the questions. There are several other questions that are there, but I think in interest of time, I will hold on to your questions, and I will move on to Dr. Binay, sir, for a couple of questions on cardiovascular disease. I know that some of the answers you've already given during the talk, so I'll try and skip those questions. There was a question on tirzepatide and triple agonist. You've already mentioned about the SURPASS CVOT, which is yet to disclose. But maybe there's a question on NT-proBNP, and now we use it as a marker for heart failure for many years. So the question is that after giving SGLT2 inhibitors, is it recommended to recheck? Do we see a decline in NT-proBNP? And what would be your experience, sir?
So as such, there's no reason to recheck, unless the patient has a crisis. You treat a patient and not a number. But if you're looking at, particularly the newer data that has come up with the DAPA as well as far as empagliflozin, particularly the data post myocardial infarction, there is no actual tremendous benefit from prescribing SGLT2 inhibitors in an acute setting post myocardial infarction. But what is interesting to note is that all the people who were put onto SGLT2 inhibitors, though their outcomes might not have improved, what did improve was their NT-proBNP levels. So, in any kind of setting, I think it reduces NT-proBNP. So, as such, I don't see any indication for measuring it. But I think if the pros answer to this would be that, yes, it does reduce NT-proBNP levels.
Sure. Thank you, sir. And I think there are several questions trying to dig your brain to ask whether there's a favorite or a best SGLT2 inhibitor or a best DPP4 inhibitor of the ones that we have available. And even now, more recent questions in the chat box I see with GLP-1 RA. So what would be your question? Is there a single best that you would choose from all the three classes of drugs?
I really don't think there's any kind of thing that you can choose from. They all have their own place. On a spinning track, you will have an Ashwin, and on a fast pitch, you'll have a Bumrah. So it's always something that you need to choose according to the patient, individualize. So I don't think there's any kind of reason to choose one from the other. Of course, with the GLP-1 receptor analogs, I think we have to be a little bit careful, because I think this is why I said I'm so looking forward to the publication of SOUL, because if we have an oral drug which improves cardiovascular outcomes in patients with atherosclerotic cardiovascular disease, that would indeed be a game changer. As far as GLP-1 receptor agonists are concerned, the best data to date still remains with liraglutide, because I feel liraglutide is the only drug which reduced cardiovascular death. That's the only drug which has advantage over the others. But I think overall, all the drugs reduce MACE and reduce stroke and MI. So there's very little to choose between the GLP-1 receptor agonists.
Thank you, sir. That answers a whole lot of your questions. The next question is on the role of diastolic blood pressure, and you very clearly stated how more recent data tells us that not to worry so much about a bit high diastolic blood pressure. But the question is on the other end of the spectrum, when we really need to start worrying about the lower limit of diastolic blood pressure.
Yeah. So I think it used to be 60, but nowadays most cardiologists and most cardiac guidelines are saying you should not aim for a diastolic blood pressure of less than 70. So, the patient should ideally have a patient blood pressure between 70 and 90 if you're trying to treat the blood pressure, diastolic blood pressure. But what happens is with age, diastolic blood pressure automatically starts to reduce. So diastolic blood pressure is not so much of a target, rather than, as the question very aptly points out, that we should be more interested in making sure that we do not drop the diastolic blood pressure too low. That is where the target should be.
Great. Thank you, sir, for that clear question. Maybe moving on to the next question now on the use of newer anti-lipidemic, hyperlipidemic drugs. You did mention them in your talk. So they're asking, when do we use it in the Indian setting? And from your experience, how is their impact?
So I'll be very honest with you. I have experience of using ezetimibe. I have experience of using bempedoic acid to a certain extent. And I have seen PCSK9 inhibitors being used by cardiologists. I myself have not really initiated anybody on a PCSK9 inhibitor. So they're wonder drugs, mind you. Make no mistake. The kind of LDL reduction is fantastic. So I know two people who are, I think I've seen three people who are on PCSK9 inhibitors, who basically are young people who've had multiple myocardial infarctions and angioplasties even as low as 37, 38 years of age. And these people, in spite of robust treatment with statin and ezetimibe, have not been able to get a target LDL below 70. And these are the people who have been put on PCSK9. As you know, they're expensive and injectable. And the results that I've seen in all these patients, as far as cardiovascular outcomes, I cannot tell, because the number is so small. But, the reduction of LDL is dramatic.
Yes, and I think adding to that, even from our experience at CMC Vellore, we've used it only in people with familial hypercholesterolemia, because statins don't work after a limit, and still they have terribly high cholesterol levels, and it does work wonders.
Do you have any ongoing studies on PCSK9 inhibitors in Vellore?
Not as yet, sir. No ongoing studies, but then we have used it in some very refractory patients, right, mainly familial hypercholesterolemia. Not as part of the trial. So thank you, sir. And then moving on to the next question, and this is from Dr. Ranbir Bhaumik, and he wants to ask whether there is any risk of SGLT2 inhibitors increasing risk of bladder malignancy. What's the opinion of the forum?
Probably not. Probably not.
Right. So that answers.
Not aware of any data.
Right. So I think they probably got confused with maybe pioglitazone or something else. But then yeah, definitely no link between SGLT2 inhibitors and bladder malignancy. So there are a lot of boring questions, but you've answered many of them. Dr. Mahima, Dr. Jain, Dr. Gabriel, Dr. Javed are all trying to figure out and find out whether there is a best SGLT, best GLP-1, or a best DPP-4, and you've very clearly answered that. It's the patient-centric approach that we take, what suits for that particular patient. More or less, these drugs are pretty much very helpful and similar. May I ask Dr. Sanjay Agarwal to have a comment before we close? The time has just flown so fast, and thank you, sirs, for answering both the so many questions. Thank you,
Thank
both
you,
the
Nitin.
speakers.
You've been such a wonderful chair.
Thank you for a
Thank
great
you, Nitin.
moderation.
I think when you have two great speakers, the time just flies and you get so much of information out of them. It's wonderful to have, two stalwarts who work in the cardiorenal area. And when I picked up the phone, both of unhesitantly said, yes, we will be there to have this discussion. And it was such lovely discussion. I kept monitoring it. But Nitin, again, thank you also for moderating this so well. I'm sure this has been an enlightening evening where we've had so much of information about these new molecules. And every day these molecules come up with newer data. And we keep wondering that will they replace all other molecules? Because you've got now a whole plethora of people, right from cardiologists, nephrologists, other than diabetologists, endocrinologists who write this. And I don't know what all is going to replace further. But thank you, Kalyan. Thank you, Binayak. I think it was wonderful to have your presence this evening. And I think your lectures were so insightful about what these molecules hold for the future that I'm sure we would love to have you back after 3 months to see what new data has come again in 3 months' time from what you presented today. So thank you very much. And thank you, Anjali, and thank you, Nitin, for keeping the entire discussion live for the whole evening. Thank you very much, all the audience, and Lupin Pharmaceuticals for helping us with this entire program. Thank you so much.
Thank you, Sanjay.
Thank
Thank
you
you.
for inviting.
Good night. Bye-bye.
Good night.
Night.
Thank you.
Good night.
Bye-bye.
Good night.